In terms of the background to why we carried out the work in the first place around heart failure, first of all, we actually have one of the highest hospital admission rates for heart failure in the West Midlands. And in addition, in the last few years, the Audit Commission had carried out a review of heart failure where they'd identified areas where our service actually needed redesigning. And it was both of those that became the impetus for the redesign work now. The purpose of a needs assessment is to understand what the needs of your population are in terms of that specific disease, to understand the services that we currently provide within this trust. By comparing those to the evidence base, which gives us an understanding of nationally exactly what heart failure services should look like, we can know where our gaps are and therefore where we need to focus our attention. In carrying out the needs assessment, we used a tool called Population Health Manager. This is actually a tool which is web-based. It has multiple different data sets within it, and it actually allows us to carry out more comprehensive data analysis, for example, looking at GP level data, also looking at hospital admissions and mixing that along with prevalence data. I found Population Health Manager a very quick and simple tool to use, which obviously, considering the demands upon our time in public health, is very valuable. It actually allows data sets to come together in one place, which sounds simple but actually is very valuable because it means that you can compare different sets of data at the same time, and as well as answering questions with that data, it can actually also allow you to ask questions from the data. In addition, the outputs are, I suppose I'd say, sort of very modern, very innovative. It's not just your standard graphs and tables that you get from it. There was a lot of geographical information that came from it, data presented in a map form, which I actually found extremely useful for working with clinicians. When you carry out a needs assessment of any disease area, you have to have full clinical engagement, and therefore in relation to the heart failure work that I've carried out, I took that to the clinical steering group responsible for heart failure. Now, normally when we do that as a public health consultant, you would take along tables and graphs, and it's often very numbers based, but it doesn't actually allow clinicians to really engage with the population that they're caring for. Whereas by using PHM, actually a lot of the data that I presented was geographically based. It was mapping data, which allowed for a greater understanding of the spread of patient need, but also in some ways just allowed them to engage more with the actual population we were talking about. It wasn't just a number, it was someone living in a specific area or living in a specific locality. And I really feel that actually assisted me quite heavily in getting the message across as to why these changes were required. To give you an example of a couple of the specific things that I looked at when using PHM, one of the first was to get an understanding geographically of the spread of heart failure across our population. I did that by looking at GP prevalence, i.e. the number of heart failure patients within each practice, and then the spread of those practices across the trust. And that allowed me to understand that actually, although we have a fair spread, the numbers are extremely varied. So you may have one practice, for example, that just has 4 or 5 heart failure patients, and then another practice in a different locality that could have up to 100. The reason why that would be so important is because to have a GP who has a smaller number of patients, they obviously are having less time focusing upon heart failure and heart failure management compared to someone who, say, has 100 patients. And the concern for me would be that perhaps their confidence would vary therefore, and even their clinical skills. Again, that's no negative reflection on the GP themselves. It's just the fact that that's the nature of clinical practice. The more cases that you work with, obviously the more confident and the better your experience is. The second example of the analysis that PHM has allowed us to do has been to compare prevalence rates, or i.e. the number of patients that have heart failure within practices, to hospital admission rates. Now, normally what you would expect to see is that one was rising, so would the other be, so that where you had greater numbers of patients in a practice, they would be associated with greater admissions. But actually, the use of the geographical mapping that PHM allowed us to do and that level of detailed data allowed me to determine that there was actually a number of practices that, although they only had small numbers of patients, were accounting for a far greater number of admissions to hospital than you would expect. Now, obviously, what that suggested to me, it was very much that it backed up the first piece of work that we did, that there may be a difference in confidence between GPs, but obviously that we need to give far greater support to primary care. In terms of the changes that have resulted, both from the needs assessment, but in particular from the work that came from PHM, I would say predominantly has related to primary care. So the understanding that PHM gave us that there were variations across practices have actually allowed me to take our community heart specialist team, take some of their focus from secondary care out of that area, and actually put it into primary care. So we now will offer titration clinics, which is changes in medication for patients within the community and within their own GP practices. We will now go in and look at registers of heart failure patients to make sure that they are effectively reviewed. And we will actually just offer a greater level of support to GPs. Ultimately, I want patients to be on optimum medication. When a patient needs support, they will have access to that support 100%, regardless of where they are in this trust. When they go to access that support, it will often be from a GP, and that GP will have immediate access to resources to support that heart failure management. And when all of those are combined, we will have a reduction in hospital admissions and patients having a better quality of life, which is the ultimate goal of any of this work.